Welcome to the Real GI Doc Show. I'm your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist with a medical practice in New York. On today's episode, we're going to talk about acid reflux. If you know 5 people, chances are you know someone with gastroesophageal reflux disease, also known as GERD. Acid reflux is one of the most common complaints I hear from patients as a gastroenterologist. With about 20% of the population suffering from GERD, it's no surprise that I end up discussing acid reflux with patients every day. So today we're going to discuss a patient with a typical presentation of GERD. We'll review how to work up and treat GERD and cover the management of acid reflux with diet, lifestyle, and medication. Keep listening to learn how to treat and prevent this uncomfortable and sometimes dangerous condition. Before we get to the case, I must inform you that the following presentation is based on a real patient case. Some details may have been changed to protect patient privacy. So, a 50-year-old man came into my office with complaints of heartburn. He was a construction worker by trade, and he complained of several years of heartburn, described as a burning pain in the lower part of his chest and the upper part of his stomach, right in the middle. The symptoms have been present for about 10 years, and they come and go. Most of the time, he feels fine, but he has heartburn symptoms several times a week, sometimes quite bad. He takes Tums intermittently, which seem to help a little bit, but then the symptoms come back later on. He states that red sauce, bagels, and eating big meals or eating late at night worsen the symptoms. He denied any problems with swallowing. Nothing got stuck when he swallowed, and he had no pain when he ate. He denied any weight loss. He denied nausea or vomiting, and denies early satiety, meaning he was able to eat a full-size meal without feeling full. He's never had a workup for this in the past, he's not had a prior endoscopy, and he has not tried proton pump inhibitors, which are acid-reducing medications like Nexium or Prilosec. He'll occasionally drink alcohol, but not every day, and he has never smoked cigarettes. On physical exam, he looks like a healthy guy with no real pain or any outstanding physical exam characteristics. He's 5'9" in height, and he weighs 210 pounds, and his body mass index is 31. So before we talk about how to work up a patient like this, let's first define GERD, or gastroesophageal reflux disease. And for a lot of this, I'm going to go right to the guidelines by the American College of Gastroenterology, which were published in 2022 and will be linked below. But GERD is the condition in which the reflux of gastric contents into the esophagus result in symptoms or complications. And there's 2 main symptoms that go along with GERD. The first symptom is heartburn, which is both the most common symptom and what this man was describing. It's defined as a substernal, which means below the chest bone, burning sensation that comes from the epigastrium, which is the, quote, pit of the stomach, that area, the top part of your stomach, underneath the ribs. It rises from the epigastrium, and it's an uncomfortable sensation that you feel radiating up towards the neck, or sometimes just sits in the epigastrium, but it's like a burning type sensation. And then there's regurgitation, which is the effortless regurgitation or return of gastric contents upward toward the mouth, sometimes with an acid or a bitter taste in the mouth. So people complain of heartburn, which is that burning, annoying feeling in the pit of the stomach that radiates to the chest, or regurgitation, which is when they actually feel stomach material, liquid or food or whatever it is, coming up behind the chest where they taste it in their mouth and it tastes like acid and it's gross. So those are the 2 cardinal symptoms of GERD, and there's many other ones that we're not going to cover today because this is not like an exhaustive review of GERD. That could take 6 months to talk about. But for this patient, he had at least heartburn, and his symptoms were somewhat intermittent, but they were going on for many, many years, probably at least 10 years, maybe longer. So how does a gastro doctor triage a patient like this? I see GERD patients every day. They are super common. It's 1 out of 5 people have GERD, and in a general gastroenterology office like my own, it's between screening colonoscopies, irritable bowel syndrome, constipation. GERD is right up there on that list of top 4 or 5 things that we see here, probably abdominal pain as well. But that's like the top 5 things that probably every community gastroenterologist sees. GERD is right up there, maybe the top 2 that we see. So it's important to kind of know these guidelines and to approach patients like this systematically, because there's just so many of them that we need to figure out a system to deal with this problem. So luckily we have our nice guidelines here. And basically what you do when you see a person with GERD, after you take a history, you do a physical exam, and you listen for all these like keywords in the physical exam that you look out for, is you start to triage patients with GERD into a couple of different categories. And the biggest thing that we look for in a history, when we take a history of someone with reflux, is we listen to the presence or absence of these, quote, alarm signs. And all an alarm sign is, or people used to call them red flags or whatever you want to call them, they're like symptoms that are concerning for some other problem, and not just simple acid reflux, or that acid reflux has caused such a problem that there's now more serious complications to deal with. Namely, we're looking out for things that sound like they could be cancer. So the biggest things that we hear that make us want to look into the reflux disease a little more thoroughly and a little faster are, we look for the presence of dysphagia, which is trouble swallowing. We look for weight loss. People with just simple GERD shouldn't be losing weight because they can't eat. That's not normal. We think about if we hear a history of bleeding, someone's either throwing up, vomiting blood, or passing blood in the stool. That's not normal. We look out for just vomiting in and of itself with reflux. And we also ask about anemia. So has someone had recent blood tests done? Are they iron deficient anemic, or have they lost blood? That's not normal with just run-of-the-mill GERD. So if we hear any of those red flag symptoms, then we get a little more worried. That patient takes a shortcut in the diagnostic algorithm and moves right on to endoscopy, because we're basically trying to make sure that they don't have cancer or some other bad illness. Now, we also look at the patient's age. So if the patient is under 50, it's less likely that they're going to have some bad disease, although younger people get stuff all the time. That's just a general rule of thumb. And we triage people. So if someone comes in who's otherwise healthy and has no alarm signs, they have no trouble swallowing, no weight loss, no vomiting, no bleeding, no anemia, and they do not have any other concerning family history, like a family history of esophageal cancer, and they're young and they're in their 30s or 40s and they haven't really done anything yet about the reflux problems, then we start with the simple stuff. We start with a trial of diet and lifestyle modification. We try a proton pump inhibiting medicine like pantoprazole, omeprazole, esomeprazole, which is Nexium, or any of those other proton pump inhibiting medicines for about 8 weeks, and we see what happens. Now, most people will feel better at that point, and then we try to stop the proton pump inhibiting medicine and focus more on diet and lifestyle changes. And if they feel good and move on with life, then they're cured, and that's great. But what happens is a lot of people come back with recurrent symptoms, and then we have to work them up further. But that's not the subject of this patient's case. So my patient fell into the second part of this triage algorithm. Someone you would not necessarily want to just put on medicine and see what happens. For him, he meets some of the criteria to screen for Barrett's esophagus. So the criteria that are established to look for Barrett's esophagus in someone who's coming in with GERD are the following. First, you have to have chronic GERD, described as having reflux symptoms for more than 5 years. He fits into that category because he's had symptoms for at least 10 years. Even though they're intermittent, they're chronic. Now, you have to have at least 3 or more of these next factors to be considered someone who can go straight to a screening endoscopy for GERD and not have to worry about doing medication trials and other things, because we want to see, based on the risk factors, if you already have Barrett's esophagus. And those are the following: male sex, age greater than 50, smoking, being white, having central obesity, or having a family history of Barrett's esophagus or of esophageal adenocarcinoma, which is a type of esophageal cancer. So if you have chronic GERD and 3 of those characteristics, then you can qualify just for regular early endoscopy and just go right to endoscopy and not have to worry about trying medicines, etc. And the reason for that is people with these risk factors are the highest risk to develop Barrett's esophagus. And if you send people out of the office with just a medication, there's a good chance that they'll take the medicine forever, or they'll take it for a little while and they'll never come back. and they'll never get diagnosed with Barrett's esophagus. And why do we care about Barrett's esophagus? Well, the big reason is that it's a precancerous type condition that can lead to esophageal cancer. Now, esophageal cancer has a rapidly increasing incidence over the last 40 years or so. So more and more people are getting esophageal cancer. And the reason why Barrett's esophagus is something you need to know about is because it's considered a precancerous type condition that can eventually lead to esophageal adenocarcinoma. So what is Barrett's exactly? It's defined as what's called a metaplastic change. So metaplasia is not the same as something that's cancer or precancer. But what metaplasia is defined as is it's a replacement of mature cells by a different type of mature cells. So, for example, if you have squamous cells in your esophagus that line your esophagus normally, those cells get replaced by intestinal cells, cells that belong more in your lower part of your GI tract. They're like small intestine cells. You should not have intestinal cells up in your esophagus. So when that process happens, it's usually an adaptive process to some type of chronic inflammation. So if you have chronic acid irritating the cells in the lower part of your esophagus, over time, you could develop reflux disease. Those cells can get burned and ulcerated, and you can get strictures. Or you can also get, or both, you can get intestinal metaplasia, which is when the squamous cells that typically line your upper esophagus change, and they now resemble microscopically intestinal cells. And some people, when this process happens, oftentimes the burning that you get from acid reflux can actually get better because the intestinal cells are a little better at handling acid. They can still get burned up and ulcerated just the same, but it seems to be like a maladaptive process where the intestinal cells grow there because you keep burning the squamous cells, and your body is smart somehow and knows that it should grow intestinal cells there. How does it know? Nobody knows that, but it's a very interesting process. Now, the reason why metaplasia is not just some cool adaptation that happens and it's actually dangerous is that cells that undergo metaplasia have a higher chance to undergo a different process, which is a little more sinister, called dysplasia. What dysplasia is, and this is a term that many people have heard, it's when the cells become atypical. They don't look normal anymore. They don't just look like regular intestinal cells. They look like cells that are undergoing a precancerous transformation. So eventually, dysplastic cells can lead to cancer. And that is bad because the process in your esophagus, the way this happens, is that you have chronic acid reflux, you develop this metaplasia, which the cells in your esophagus begin to resemble intestinal cells and not typical squamous type cells. And eventually, those metaplastic cells with continued acid irritation and inflammation can transform into dysplastic cells, and eventually with more inflammation and more irritation, those dysplastic cells will undergo further changes in DNA and that will lead to cancer forming there. And once you have esophageal adenocarcinoma, which is esophageal cancer, it is not a great disease to have. And the mortality and the treatments needed are not anything that someone would consider easy, and not anything that someone would consider a low-risk situation. So really want to prevent esophageal adenocarcinoma as much as possible, and the way to do that is to prevent Barrett's. And if you can't see Barrett's without an endoscopy, it's very hard to prevent something. So the reason that we screen people who have these risk factors is because we want to pick up on people who have Barrett's esophagus before that metaplasia turns into dysplasia, because there are some interventions that you can take when someone has Barrett's that potentially could prevent them from getting cancer. But you have to know that they have Barrett's in the first place. So going back to our patient, did he fit those criteria? He did. He's white. His body mass index is 31. He's had chronic reflux. And he's a man. So that's all you need to do a screening for Barrett's in someone who has chronic reflux disease. So what happened with our patient? We did an endoscopy. He went to sleep. We took a look down with a little camera. He woke up and felt great. And we got some nice pictures and biopsies of his esophagus. Just to summarize, if you're not familiar with upper endoscopy, it's a procedure that's done typically in an office-based setting. There's an anesthesiologist involved that sedates the patient a little bit. They feel no pain and have no awareness of the procedure. And while the patient's asleep, we introduce a very small camera. It's about the width of a small pinky finger in the mouth. It goes down the esophagus. We look at the stomach and the first portion of the small intestine called the duodenum and take biopsies and can diagnose many different upper GI conditions. Now, in this case, we were looking at the esophagus. We look at everything, but we were looking particularly for signs of Barrett's esophagus. And what our 50-year-old man had was he had severe esophagitis. Now, esophagitis means inflammation and ulceration in the lower part of the esophagus that comes from stomach acid. And it's graded on a scale from no esophagitis to minimal esophagitis to moderate to severe. And this scale is called the Los Angeles classification. And it's kind of beyond the scope of talking the details here because this is not the right audience. But he suffices to say that he had severe esophagitis, which was graded Los Angeles grade D esophagitis, which is the most severe that you can have on that scale. And what that means, if you're looking down at the esophagus, is that he had ulcerations from acid in the bottom part of his esophagus that extended high enough up the esophagus and were circumferential, meaning it was the entire circumference of the esophagus was involved in these ulcerative changes, and they went up at least a few centimeters from the bottom part of his esophagus. So it's dramatic to look at, it looks painful, and this is what this man had. Now, what we do on an endoscopy is we take biopsies of that area. We want to check for precancerous cells, we want to look for Barrett's, we want to see what that's all about, and we also take biopsies of the stomach and look for H. pylori bacteria and other conditions. So his biopsies came back negative. There was no evidence of Barrett's. It just showed erosive esophagitis type changes, and the recommendations for him were to start some diet and lifestyle changes and also to start a PPI medication. He was prescribed Protonix, which is pantoprazole, 40 milligrams a day, and I could have given him a higher dose or a different PPI, but that was what we settled on. And he was also counseled on diet and lifestyle changes. And that's a big part of how we treat acid reflux because diet and lifestyle are a big part of how people get acid reflux. So what kind of counseling do I give people here in the office when they are diagnosed with reflux? Well, I give them a handout with all this stuff on it, but I also explain it to them. And really, the diet and lifestyle stuff for acid reflux revolves around a few things. It's kind of weight management, it's substances, and it's eating patterns and sleeping patterns that we talk about. So weight loss is a really big deal with acid reflux. Weight gain, even a few pounds more than you should be, is associated with development of GERD, and obesity is associated with the development of acid reflux conditions and complications from acid reflux. So if a patient is overweight or obese, they are counseled to really embark on a lifestyle change and a diet change to induce some weight loss. And that's the topic of 20 podcasts to talk about how to actually do that. But we do try to address the weight because that's a huge factor in most people who have acid reflux. There is some type of weight factor involved. So we address the weight. We talk about substances. So smoking and alcohol should be stopped or limited to the degree that's feasible for that patient. And we also talk about eating. So we tell people don't eat late at night. Try not to eat within about 3 hours of going to bed. You don't want to lay down on a full stomach and have acid being produced all night when you're unconscious and stuff is coming up and burning your esophagus. When you're in that flat position where gravity is not keeping things down in your stomach, it's just kind of letting everything percolate to the top of your stomach and cause problems. And you want to avoid bedtime snacks and all that stuff. And also you want to sit upright after you eat a meal and make sure everything goes down. There are several foods that we tell people to avoid. The biggest ones are coffee, chocolate, carbonated beverages, spicy foods, acidic type foods like citrus, tomatoes, etc., and foods with high fat content, and also processed carbohydrates. So that's another thing that's been linked to reflux is large amounts of processed carbohydrates. Everyone thinks that a bagel or a piece of cake or bread is going to, quote, soak up all the stomach acid. But in reality, what it does is it promotes acid reflux. And it's also not really a great thing to eat in general for various different reasons. But we tell people to watch out for the highly processed foods and the white starches, and also to cut back on high fat meals because those take a long time to get digested and they sit in your stomach for hours and hours, and you're making acid that whole time. So those are the main lifestyle changes. There's also a few other ones like not wearing tight-fitting garments and potentially elevating the head of the bed under blocks or the headboard of the bed, lifting it up a few inches off the ground to allow gravity to help while you're sleeping. But that's practically very difficult for people to do, and they kind of roll out of bed and their spouse doesn't like it. So that's like the last thing they try. And also when you sleep, you want to sleep on your left side if you can. So you promote the stomach contents staying in your stomach because of gravity. Your stomach is located more on the left side of your body than it is on the right side. And when you lay down with the left side down, gravity is keeping stuff in your stomach and preventing it from going up into your esophagus. When you sleep with the right side down, your stomach is now above the opening of the esophagus, and gravity is keeping everything right at that gastroesophageal junction. So all it takes is a little nocturnal relaxation of the lower esophageal sphincter muscle that holds the stomach and the esophagus as separate compartments, and the gastric contents are right there ready to be refluxed. So if you want to prove that, you can eat a big meal, lay on your right side, and try to burp and see what happens. And you will most likely develop some gross regurgitation because stuff in your stomach is right there pushing up into your esophagus. And try it out one time. It's really fun. It's a proof of concept. But it's actually disgusting, so don't try it. But what else did we tell this patient? We told him to start his PPI therapy, and then we made a follow-up for him in a few weeks to see how he was doing. He came in for a follow-up in the office, and he noted that he felt kind of the same, and he did not start his medicine because he did not want to take any pills for his condition. So we talked more about how he has very severe esophagitis, and diet and lifestyle is great, but it may not fix his issue. But he didn't want to start any medicine. He said he'd focus on diet and lifestyle as hard as he can. And we scheduled a repeat endoscopy in 3 to 6 months because A, we want to check that the esophagitis, the inflammation in the esophagus is healed and there's no ongoing damage. And B, we want to take repeat biopsies for Barrett's esophagus because sometimes when there's really bad inflammation, you can't actually see if there's Barrett's esophagus there. It is very difficult for the pathologist, which is the doctor that examines the tissue, the biopsy tissue under the microscope, to tell if there's Barrett's esophagus, if there's dysplasia, or what the deal is. When everything's on fire, it's very hard to see anything past that. So it's a standard procedure that when someone has severe esophagitis, either class C or D, then we bring them back in for a repeat endoscopy. So for this gentleman, we decided to do another endoscopy in about 6 months because he was not interested in medication and he wanted to take some time to focus on lifestyle changes. So fast forward now 6 months later, we bring him back in, we do another endoscopy, and it looks the same. There's been no difference. The esophagus looks like it still has severe LAD esophagitis, which is not really a surprise because he wasn't taking medication, and he told me that he was really good with the diet changes for a couple of weeks, but then eventually kind of went back to his old ways of eating and was just taking Tums, etc. So nothing really changed. And at that point, we had a discussion that 6 months of diet and lifestyle, there was really no big difference. Can we try a medication and see what happens? And we'll repeat the study in 6 months on medicine and see if there's any difference. And we reiterated the discussion or the concern about developing Barrett's, developing esophageal cancer. He's a young guy, and he doesn't want to develop a potentially preventable complication from this severe acid reflux. So he did agree to take Protonix, or pantoprazole, which is a PPI medication, once a day for 6 months, and then we repeated his endoscopy. And on the repeat endoscopy, I could tell that he was taking his medicine because everything healed. He had no more erosive esophagitis at all. And the bottom part of the esophagus was a little bit irregular looking, and that could be Barrett's esophagus, or it could just be the healing process after that severe esophagitis from all the injury from the burned mucosa of his esophagus, or the burned lining of his esophagus. So we take repeat biopsies of that area, and we submit them to the pathologist, and we came back with negative for Barrett. So there was no Barrett's esophagus. It was just the way the esophagus looked after that severe esophagitis. So that's great news for the patient. He prevented himself from getting Barrett's. He now feels 100% better. He states on the medicine that he actually feels completely fine, has no more need for Tums, and he actually would like to continue the medicine because he feels so good on the medicine. I think he maybe didn't realize how bad it felt to have that esophagitis because he was used to it for so long, but when it went away completely and healed, he must have felt better and wanted to take the medicine. So my typical path there, since he has no Barrett's esophagus, would be to keep him on that dose for now, which is the standard 40 milligram a day dose, and eventually we'll try to push the diet and lifestyle changes more and eventually try to bring his dose down to the minimal effective dose. And now for that medication, I would drop him down to 20 milligrams if he wanted to be dropped at some point in the future, and then maintain that and see how he does. And eventually in a couple of years, go down there again and repeat an endoscopy and see if there's any reflux damage or if the erosive changes have come back, and also rebiopsy for Barrett's, because you're always on the lookout for these kind of changes. Although we think that these proton pump inhibitor medicines do reduce the risk of esophagitis changes turning into that Barrett's metaplasia and turning into dysplasia. So by adequate treatment of the acid reflux injury in the esophagus, we can potentially prevent people from getting esophageal cancer. Now, what do the studies say, or what do the guidelines say? The guidelines recommend someone who's had severe reflux esophagitis, like our patient here, that he actually maintains himself on proton pump inhibitor medicine indefinitely. That's with or without Barrett's, which is kind of what we recommended, but the caveat there is that if someone really wanted to do the diet and lifestyle changes to the extent they are possible, and they were successful in losing the weight and potentially changing the eating patterns, not eating late at night, watching out for certain offending foods, and maintaining a weight loss over time, potentially some of those patients could come off the medicine entirely. Now, that's the theory. The proof is really in what the patient's able to do. It's very difficult to lose enough weight and maintain that weight to reduce your acid reflux to zero. I've definitely seen people do it, but it is a challenging situation to embark on. So I tell them that in reality, they'll be on this medicine for the indefinite future, but there's always a chance that with very aggressive diet and lifestyle changes or significant weight loss, that the symptoms can be basically reduced to zero, and then we can take them off the medicine with no issue. And that happens, but the more common situation is really that someone ends up staying on a very low dose of the antacid medicine because it is useful, it does work, the risks are very low, and the risk of the risk of that patient developing Barrett's esophagus and esophageal cancer drops dramatically. Okay, that's the end of today's episode. I really hope you enjoyed this case of acid reflux and found the information interesting, and hopefully you can use some of this information in your own life. And if you're one of those people that has more than 5 friends, I'm sure one of you suffers from acid reflux, so be sure to share this with them and maybe they'll get some useful tips on how to manage their reflux. That being said, if you have any questions for me, comments, or anything like that, please find me on social media under the username RealGIDoc on any platform you can imagine. And you can also send me an audio question if you go to realgidoc.com, and you can leave a voice question there with ideas for future episodes or for question and answer episodes. That's it. I'll see you next time.
That's it for this episode of The Real GI Doc Show. Make sure to join Dr. Gandolfo next time to explore another interesting topic in gastrointestinal health. And remember, the views and opinions presented in today's episode are for informational and entertainment purposes only. Nothing discussed in this episode should be considered or used as a substitute for medical advice, diagnosis, or treatment. If you're experiencing a health issue, please consult with a doctor or a medical provider in your area. Thanks again for listening to the show.